Hello and welcome to our first of, we hope, very many roundtable series focusing on the impact of liver disease and liver cancer specifically on communities of color and other marginalized communities. I'm Donna Cryer. I'm the CEO and founder of the Global Liver Institute. I am blessed to say that at the time of this airing, I will be 28 years post-liver transplant. So we know what innovation can do. We know what can happen when healthcare works for people. We have a commitment at the Global Liver Institute to make sure that research and care and policy work for all people. We have this opportunity throughout this month of October, where October is for livers and everything turns burgundy, and all things are about liver health, our solutions for liver diseases, and particularly liver cancer, which is the third deadliest cancer, which is the cancer that without resolving, we cannot meet the goals of the United States White House presidential goal for eliminating liver cancers as part of the cancer moonshot. It is also the cancer that disproportionately affects African Americans, particularly African American men. And so I have today, as part of our series of community conversations across our October is for Livers campaign, this fantastic roster of national and international experts on the impact of liver disease and liver cancer in African American and African communities. And so without further ado, I'm going to introduce Dr. Joan Culpepper-Morgan, who is Chief of Gastroenterology at New York City Health and Hospital in Harlem, New York. I have with us a friend of GLI, of course, Dr. Rotonya Carr, who is now Chief of Gastroenterology at the University of Washington in Seattle, Washington, and also a founding board member of the Association of Black Gastroenterologists and Hepatologists. I have with us Dr. Nicole Goldwyn, who is amongst the team who were the very first awardees of the Global Liver Institute's Excellence in Liver Health Equity Awards. She's a co-founder of the Black Liver Health Initiative in New York, and one of our fantastic nurse practitioner leaders that we always want to recognize and lift up. I have with us Dr. Samuel Antwi, who will bring us the full diaspora that we need to include when we think of addressing these issues, and is on the board of our African Hepatobiliary Partners organization, who we have been so proud to be able to support. I also want to give a shout out to our founding board member, Dr. Dr. Lewis Roberts, who has been, of course, instrumental in that area of African and U.S. Liver cancer partnerships. And so I have with us also Dr. Patricia Jones, who is a hepatology specialist at the University of Miami in Miami, Florida. Our hearts out to our Floridians. And so I thank you all for joining me today to discuss this really important topic. Welcome.
Thank you.
So, Dr. Antwi, we're going to start with you. You are a geneticist, a molecular scientist, a basic scientist. And so why don't you start us off with helping us to understand what liver cancer is and how it starts?
So liver cancer is a very complex disease. Even though liver cancer originates in one organ, the liver, there are various subtypes of liver cancer. The most common one is called hepatocellular carcinoma, which originates from the hepatocytes in the liver. There is a very second most common one is called intrahepatic cholangiocarcinoma. So the bile duct runs through the liver, and sometimes cancers occur in the bile duct within the liver, and those are what we call the intrahepatic cholangiocarcinoma. There are other less common subtypes of liver cancer that occur, but the two main ones that we often see is the hepatocellular carcinoma and then the cholangiocarcinoma, which either originates from the hepatocytes, which is the liver cells, or the bile duct within the liver. And there are several factors that causes liver cancer. Genetics is one of them. We have common genetic variants that we inherited from our parents that we may likely pass on to our offspring. Those increases our risk of getting liver cancer. There are also some rare variants. These are rare conditions. We don't see them very often, but they have a very high risk of leading to liver cancer development. And there are common risk factors that we can do a lot about, such as hepatitis B and C viral infection. Alcohol abuse can result in alcoholic cirrhosis that can also result in liver cancer. In Africa, we see aflatoxin exposure, which is some fungi that grows on grain when they are stored in under moisty conditions. These fungi can actually grow on the grains and can lead to cancer development. And then we have other causes such as non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. That is becoming a major epidemic, not only in the Western world, but also in Africa. Non-alcoholic fatty liver disease simply means you have fat accumulation in the liver, usually defined as fat accumulation in excess of 5% of the liver mass. That is non-alcoholic fatty liver disease. There's a spectrum. Usually, if you have that condition, it doesn't really result in anything, but then it can progress for some people to a condition called non-alcoholic steatohepatitis, which means there's significant inflammation in the liver. There's hepatocellular ballooning, or the hepatocytes becomes bigger. And those conditions can also progress to another phenotype within the liver called fibrosis. There are various stages of fibrosis from 0 to stage 4. Stage 0 means you have no fibrosis at all. Fibrosis just means the liver stiffness, beginning of the scarring condition of the liver becomes really stiff. And we can grade it from 0 to 4. Stage 3 is usually referred to as bridging fibrosis because it lies within the spectrum of non-alcoholic steatohepatitis and then another condition called cirrhosis. By fibrosis stage 4, most people are already in cirrhosis. And cirrhosis is a condition which is irreversible for most people. It's an irreversible scarring of the liver. Cirrhosis can be compensated where the liver can be able to perform some of its function, or decompensated where it's significantly compromised in its ability to perform its normal functions. And from cirrhosis, you can lead to either liver cancer or end-stage liver disease. But the main point here is that there are some things we can do to prevent us from getting chronic liver diseases like cirrhosis and liver cancer, and there are some that we can't. Some of the things that we can't do are those genetic factors that we inherited that are likely to predispose us to developing these conditions. Those we cannot do much about. What we can control is our ability to prevent us from getting a hepatitis B or C viral infection, getting excess alcohol intake, which can result in alcoholic cirrhosis, and then also NASH and NAFLD, which are mainly caused by obesity and diabetes. So alcohol, hepatitis, and obesity and diabetes, we can do something about it to reduce our risk for developing the disease. But the genetic ones sometimes can be very challenging. What we can do with the genetics is that we know we have this genetic syndrome that can lead to liver cancer development. So we can reduce the effect of that particular genetic variant by eliminating alcohol, excessive alcohol consumption, reducing our risk of getting diabetes, maintaining a healthy weight. So when we do those things, it significantly reduces the effect of the genetic components leading to cancer development. So overall, that is what I would say how liver cancer generally progresses. Thanks.
Thank you so much. I'm going to pick up on a particular part of that and give this over to Dr. Carr, who is an expert particularly in the non-alcoholic steatohepatitis or fatty liver disease and NASH that many people in our community have never heard of. And so tell us why NASH is important, increasingly important, and how so many of our community are overweight and or thick, and how that it can be beautiful, but it may not be the best for your health, and it may have some liver health implications to that.
Donna, thanks for that question, and Sam, thanks for the introduction. All things liver and liver cancer risk. I have very little to add to that. I'll focus on NASH. And as was stated, non-alcoholic steatohepatitis, or NASH, is one of the types of fatty liver disease, non-alcoholic fatty liver disease, and this just means that the liver has too much fat, and the extra fat can get there from a number of ways. But in the world now, this condition accounts for about 30% of the U.S. 30% of individuals in the U.S. have this condition, even if they don't know they have it. And about 25 to 30% of the worldwide population has it. And I would also like to amplify in kids in the U.S., about 10% of kids. So this condition is not going away. Many are at risk and don't know they are at risk. We also know that many have been diagnosed with the disease and still don't know that they carry that diagnosis. So we have a lot of work to do. The main risk factors are obesity, as you mentioned, people who have pre-diabetes or diabetes, or what we call the metabolic syndrome, where perhaps they have high cholesterol panels or high blood pressure, and in addition to being overweight or obese or having diabetes. So these metabolic risk factors are what we understand are what put people at most at risk. There's also the genetic component that really has accounted for more than half of the risk of this condition. What I would like to emphasize here for this particular panel on Black health is that although the prevalence in African American communities and African communities is not as high as some other racial and ethnic groups, we also can get it. Oftentimes, individuals will go into their doctor's offices, and this is not thought about as something that could be happening because of what they look like, and that's not right, and that's not okay. This disease can happen in anyone, and so that is the message. The other message is that it's a highly preventable disease with dietary guidance, exercise. It's also a highly reversible disease when we learn about it early. In terms of liver cancer, this is really the major contributor to the increase in liver cancers we're seeing across the globe. So we have a lot of work to do, and there's no reason in 2022 why anyone should get liver cancer from this condition, because it is a highly preventable, highly reversible disease.
Thank you so much. Dr. Culpepper-Morgan, in addition to all of your duties, you also train fellows. And so are today's medical students, fellows, young doctors, are they being trained in liver health, in how to diagnose patients with a variety of liver diseases that may lead to liver cancer, and how to talk to people about that? Is that part of their training?
Absolutely, and thank you for that question, because tomorrow's leaders and tomorrow's caregivers have to be very aware of a lot of different aspects of liver disease. My fellows, and because we are practicing in Harlem and really in one of the hot spots for the development of hepatitis B, hepatitis C, HIV, and liver disease, liver cancer, all of these intersections are very much at the forefront. So our fellows see a lot of that. And say specifically regarding liver cancer, we have a very high West African population. And we do have to talk to our young West African immigrants regarding hepatitis B and the risk of hepatitis B in them developing liver cancer. And this is particularly difficult for trainees, because many of these patients are the same age as they are. And they are talking to them about something that seems very, very far off. I'm 35 years old. I feel very healthy. yes, I have hepatitis B, but my brother had it and he did fine with it. Why are you trying to scare me to tell me that I'm going to have cancer? And so my fellows, and I should say parenthetically, many of them are West African. So it's a very personal issue for them. But it is in fact something that they learn to do, and that they learn to do it very well. And we monitor our hepatitis patients very carefully, our hepatitis B patients every 6 months, looking for liver cancer. Of course, a fair number of hepatitis C patients, again, different group, former IV drug users, many of whom don't even want to think about that former life. They've cleaned themselves up. And you have to have a certain amount of sensitivity to talk to them about something that they did in the past that may come to affect them in the present. And they too have to be monitored for their development of liver cancer. So overall, casting a wide net and trying to bring in as many patients for surveillance as you possibly can is a very important part of our educational as well as community health goals.
You truly are a leader in that. I know so many other institutions that struggle with that. And I hear from so many of our patients that they've never been screened for liver cancer, even though they have pre-existing liver diseases. So I'm going to go to Dr. Jones and ask, we've seen data that even patients who have healthcare coverage from Medicaid, Medicare, private insurers with viral hepatitis are not getting treated for hepatitis C. They may not have gotten their hepatitis B vaccinations. They're not being screened for NASH. There just seems so much for patients to overcome to be able to get the liver healthcare that they need. I feel that every liver patient, given the levels of stigma, have challenges, and there are disparities in liver care for everyone of every color with liver disease. But what are some of the struggles that African American and African patients in the United States in particular have to be able to access the care that they need for their liver health? Dr. Jones.
Thank you so much. This is one of my favorite topics. And I know in the beginning you mentioned innovation, and we've thought a lot about innovation in some regards, but not really in terms of the way that we deliver care to various populations. And I think that one of the biggest challenges is actually making people aware of their status. And besides stigma, there are a lot of challenges that sometimes we as healthcare providers forget really impact someone's ability to find out. For example, are they able to get off of work to come to the doctor? If they come to the doctor, how long will they have to wait? Will they be able to afford the copay for labs? And so these are real issues that I think our patients are dealing with and impact them even coming to care. And so some of the approaches that I think are important that we think about is bringing care to the community. And this isn't really a new concept. I mean, this is sort of the way healthcare was delivered in the past. But thinking about meeting people where they are and really understanding the challenges that they face individually, because every patient is different and their challenges are distinct. So I think us as a community doing a better job of trying to understand what they know about hepatitis B or C. What have they heard? Because there's a lot that people may have heard. Dr. Culpepper-Morgan mentioned some things about, well, my brother has hepatitis and he's been healthy. And so, but also there are lots of other things that people are hearing from their community about, well, what behaviors you may or may not have done that may have led to this. And I think there's a lot of personal blame that people put on themselves when they have liver disease. I mean, I think people can probably attest to this. One of the first things that people say, especially people with fatty liver, when you tell them that they have cirrhosis, is that, well, I never drank, right? Or when you try to tell them, your labs actually show that you've had hepatitis B in the past. Well, how? I never got sick. And so there's a stigma that I think prevents people from trying to learn more. But then it's where do you go if you don't have access? if you are unable to get to a primary care physician to be screened, if your primary care physician doesn't recognize the importance of screening you for hepatitis B, C, or fatty liver disease. So I think that there are a lot of challenges in the community, really, with awareness. So I'm really happy that GLI is taking the initiative to put this roundtable together, because I think that that's a step in the right direction towards achieving health equity, making people in the community aware of their unique risk factors. I hope that answered your question.
Absolutely, absolutely. And Dr. Golden, you and your colleagues really have put together a fantastic model of going out to the community, addressing, understanding, and asking for community needs, and then working from there. And so, what have you learned about what the community knows about liver disease and what they want?
Thank you for that question, Dr. Cryer. Our community, what we have found with the Black Liver Health Initiative in going out into the Black community and assessing their level of knowledge and readiness and access to liver care, what we found was there was a huge component of medical mistrust. And simple things like medical research that we see as providers as having a benefit, people are still very weary to engage in medical research for very known reasons. And in addition to that, we found that patients lack access. They may not know the primary symptoms of liver disease. They may be engaged in medical care, going to their primary care doctor. I think Dr. Carr had mentioned that. And they still don't know that they have liver disease or how to go from that local provider to a specialty center. Awareness was another barrier that we found. And then just going from having all that knowledge to, let's say, a transplant facility, if you have end-stage liver disease. The problems with liver disease is so multifactorial. I know a few mentioned, that there are so many causes and so many myths and still so much bias. For example, if you have liver disease, maybe you drank a lot of alcohol, and most people don't realize that you can have fatty liver disease with a normal body mass index. That's real. The other thing is, just in some recent studies that have shown that sometimes in African Americans, we tend to, that MEL score that we use to really look at how severe liver disease is, we may have less, a lower number on that score, but still have really advanced disease. And so some of the screening tools that we use where we do like our MRIs or ultrasound every 6 months, we may need to look at that and be a little bit more aggressive in the African American community so that we don't miss liver tumors that can develop with, even lower scores like your albumin, total bilirubin, those numbers that we look at. So it's just so complex. But the barriers that we found definitely were awareness, access, medical mistrust was huge. And so, we're still pressing our way through and trying to mitigate those barriers.
And we're so grateful for you, and we're so excited to partner with you in increasingly robust ways to do that. I want to touch on the research issue a little bit. Maybe go back to Dr. Carr. I know, NASH clinical trials need so many patients. Clinical trials that are validating non-invasive technology so that we don't need biopsies anymore, which I think would be a barrier for a lot of people. If you already mistrust the medical system, sticking that long needle, and I've had 6 liver biopsies, so I mean, like, sticking that needle in there is not how you help get trust. But so what should people be thinking about if they were approached to participate in a clinical research study? How do you talk to people about participation?
Thanks for that question. Especially in the Nash field, this has been a big barrier, but I would say in all of the liver fields, we have very poor representation of Black people, which is why still in 2022, we don't think about certain diseases even happening in Black people because we have been understudied. But I usually, for example, when I'm training physicians, fellows, residents, and really helping patients engage in the innovation of medicine, if we all just take an unbiased approach, we offer the same opportunities to every single patient who walks through the door, no one will get missed. We don't have to necessarily think about, okay, well, this is an African-American patient. Do I tell them about clinical trial opportunities or don't I? Because they're going to have so much mistrust, and I don't want this to impair the patient physician encounter. There are ways that we can talk about clinical trials perhaps differently with different groups, but it absolutely should be brought up in every conversation with every patient, especially if one is working at an academic institution. I have it as a line on every single note. Every patient who comes in, you may get called to participate in a clinical trial because there's a lot that's going on. What I've been really encouraged about is there's some active work really emerging from community outreach and ways that we can communicate better with different groups of people. And so perhaps there is something we will learn from that going forward. But I just say take an unbiased approach, introduce the clinical trials, what the possibilities are, and then let the patient lead you in whatever direction they're going to lead you and respond accordingly. Because there's so many who are going to be interested. I've been really, so CVS, as many of you probably know and have received emails if you use that pharmacy, they are sending out emails to their customers asking for clinical trial participation. I've received a number of them, and I finally opened one just to see, how they're talking to patients, and I really loved it. I thought it was very simple language, really easy to follow and understand. And I thought, for people who might be fearful, maybe they would be okay with this approach, but really just taking, I think, an unbiased approach, making sure it's offered to everyone. It's the only way we're going to overcome this hurdle.
I think that having CVS and Walgreens and Walmart and LabCorp and Quest, in the communities and bringing research to where people normally are is a good thing. I know personally I'm in a CVS at least 3 times a week. So if that's where clinical research is happening, they're more likely to, make it possible for me to participate. I think that, my message to patients is I want to make sure that the medications that come out, and they will eventually come out and be approved, that there's somebody who looks like me, who is like me in the trial, so that I know that the medicines actually work in me. And so if we want medicines to, work for us, we have to participate in the trials to begin with. And so I think that that's really important, not only for the individual, but for the communities to recognize that there is this, larger benefit to participation and a larger importance to participation for all of us.
Yeah, and those who run the trials, I'm not a clinical trial researcher, have to make sure that they are reaching out to diverse populations. If you are at a site where no one in your community, is minority or very few, then you have to collaborate with other populations at other sites to make sure your trial is robust enough, and also bring on investigators who come from diverse backgrounds, because there's important learning in that, and even how you may design the trial could be impacted by those different viewpoints. But I think oftentimes we're so siloed in our academic centers and communities that we forget the basics, but it's really not complicated. we know that the larger N, the more diverse N, I mean, we know this, from the genetic studies that, we are also excited about, and we will get closer to the truth. COVID research trials, I think, did a really good job of making sure that there was inclusion, and we learned a lot about different populations. That was ultimately very helpful when we could talk to communities of color and say, hey, people who look like you were in this trial and they did fine too. So that's really very important.
Absolutely. That's one of the things that I'm really proud of GLI, that we were able, while the design of the protocols for the COVID vaccinations, while the recruitment was going on, we were able to have conversations with those sponsors to be able to say, really, like, what are the numbers? How many? And they were able to, have very candid conversations about their recruitment efforts and the efforts that they were doing to make sure that there was diversity in, so that, months later, I could have conversations in confidence with people in the community who were hesitant. I was like, no, I talked to them myself. And we know, I saw those numbers, I saw what was presented to the FDA. And so, but we couldn't have that confidence later on if we didn't have those conversations and those relationships at the beginning and during the research process. So both are important.
So important. And the patient advocacy groups will be the other tier of that. Once we get it right from the design and all of that, then the patient advocacy groups can work to do their right, to bring in the patients.
Right. Frankly, we don't recruit for any trial as a GLI policy that patients have not been involved in the design of the trial. So just as a global statement. And so we work much more upstream now in helping make sure that they are patient-centric and as culturally sensitive and as open to helping to solve questions of what does genetic diversity look like in global trials, for example. And we feel that the outcomes will be much better in the regulatory and and post-market environment if we've been involved up front. So Dr. Antwi, this brings me to you, not only in sort of general research, but in genomic research in particular, which for so long has been based on samples from Iceland. How important is it for people of color to participate genomic samples and to be part of genomic studies, when that seems to be just very sort of off-putting or scary for people to have their DNA? But can you tell us how important it is for us to be in those pools?
It is incredibly important. To be honest with you, all we know about the genetics of HCC is mostly based on white people. So most of the genetic studies have been done among Caucasians, so we know which variants are associated with risk for Caucasians. The genetic etiology of HCC among Africans or African Americans is virtually unknown. We have no knowledge of that at all. We may have some unique genetic variants that increases our risk for developing liver cancer, but we don't know that yet. So we are not able to stratify patients who have high risk of developing cancer versus those who do not have that high risk. It is incredibly important that Africans and African Americans actually participate in these genetic studies. It's not hard. It's just like going to the doctor and getting a blood test for your cholesterol level or your ABO blood type or something. Just give a little bit of your blood. They will just separate it. They'll fractionate it into various components and separate the DNA from that blood, and then use the DNA that they get to do genetic sequencing. We can do sequencing to identify rare variants that are associated with risk, or we can include in a large pool of samples from Africa and African Americans for genome-wide association studies to identify those variants that are peculiar or unique to the African American or the African patient. It is incredibly important. I would advocate for all of us to be part of any such initiative. And that is some of the work we are doing with the Africa Hepatopancreatic Biliary Cancer Consortium, where we are trying to recruit people from various countries in Africa. hopefully include African American samples as well, so we can have a big study done among people of African descent. It's not that hard at all, and I think it's incredibly needed. We need to understand the genetic basis of liver cancer among Africans, and it's a good initiative that will advocate for everyone to be involved in. Thank you.
Absolutely. Thank you. And I think that you made a very important point about how easy it is. And part of this, a theme of this conversation about how we need to and how we are making, doing all of these things that we're recommending easier for people to do in the course of their lives. So Dr. Culpepper-Morgan, tell us what, cancer care looks like, or liver care overall. In Harlem. I know it's probably different than in Miami and in Seattle, Washington. In many ways, it can be the same. But what would a patient coming to your institution, what would it look like for them? How many doctors would they see? What types of tests would they be expected to take if they're going to take care of their liver and avoid liver cancer?
Sure. I'd just like to say one point on the last.
Please.
We are involved in the All of Us study here at Harlem Hospital. And we were chosen as a site because we are serving communities of color with about 60% African American, and about 35% Hispanic. So that, and we've had very, very good participation from our patients in the All of Us study, which is collecting genetic material from everyone. And we have encouraged patients to participate in that study by using other people of color to recruit. And that has been very successful. So that we do get a very robust referral from our primary care doctors, as well as our infectious disease colleagues, who often come across our patients with liver disease. And unfortunately, we get referrals from the emergency department, where patients will come in for an unrelated issue and are found on CAT scan, or found on, they get blood tests and their liver function abnormalities are found, and they get referred to our clinic. When that happens, we are teaching institutions, so they're likely to see a trainee, either a fellow or a resident, and those cases are presented to an attending. And we have a pretty standard protocol of where we slot patients in. And as I said before, we see a lot of patients with the viral hepatitis, and then we see a number of patients who are dually infected with either hepatitis B or C with HIV, which adds additional challenge. We see far too many Hispanic patients, especially with advanced liver disease, and I'm seeing a lot of 20 and 30-year-olds with advanced cirrhosis. And unfortunately, many of these people are undocumented, and we're unable to get them listed for transplant. But we do try to do that if we see patients with advanced disease. Columbia is our academic institution, so that's usually where we make our referrals. I would say that yes, every 6 months, once we get a patient and we identify the risks, obviously the patients with hepatitis B and C who require treatment are given treatment. The patients who have risk factors that mean that they could develop liver cancer are placed on a 6-month turnaround. Most of them do come back. Some of them don't, because they don't believe it's serious, but we try to track them down when we can, because we do have navigators. But the other thing I wanted to make sure I mentioned is vaccination. And vaccination is a hot topic nowadays. Unfortunately, vaccination has been demonized. And it's so important, if you have a patient with hepatitis C, to vaccinate them for hepatitis B if they have not been vaccinated, B and A. This has become more challenging. It used to be nothing. The patient came in, they had hepatitis C. We would start them on therapy and we'd say, oh yeah, and then you got to get your vaccination for hepatitis A and B. And now you say that and they're like, vaccination? Well, what are you talking about, doc? What is that? Why do we have to have that? And so it's gotten a little bit more difficult, but it's so important because that is part of the prevention for these things. And then one last thing, a favorite pet peeve of mine regarding fatty liver is high fructose corn syrup. And we always tell our trainees, look, you have a very limited amount of time to talk to these patients. And, you can't give them the full dietary lose weight thing, blah, blah, blah. But you can tell them, read that label. And if you see high fructose corn syrup, don't do it. And metabolically, it's poison for the liver. We know that it increases the development of fatty liver. There's evidence now that it may be a precursor or increase the development of colon cancer. And I'm wondering if liver cancer is maybe not far behind that. So high fructose corn syrup is something that, again, short period of time, don't eat it, don't do it, read the labels, vaccinating the patients, 6-month follow-up. And that's pretty much how we do it at Harlem.
That's how we do it at Harlem. I love it. Yeah, new tagline. I think that's really important to bring this into the realm of things that people are already doing or thinking about, or there's some easier steps that they can do on their own. Put the soda down, put the sugary beverage down, put the juice down. And then there are, things that you need to work with the medical system to be able to do. But as we started off talking about, 70% of liver cancers are preventable. They are preventable. We don't have to have them. And so doing these individual steps, as well as the steps with your healthcare team, are things that are within everybody's reach. And, as a patient, with often long checklists of things to do from my doctors, it can be overwhelming. And so I just take one at a time. I get this, schedule this vaccine, and then, put the soda down, get them out of the house, and just one thing at a time until we end up with, a whole lifestyle that supports liver health. So I don't want this to be daunting, for people. It's not something that you need to, just do in a day. But it's a process, but it's something that's very doable with the help of all of these wonderful people here, from all these different areas of medicine. And so that's what I want people to take away, that this is very doable. And I want to go to Dr. Golden on the transplant side. Too many people are, as we've been discussing, are diagnosed so late when they need a transplant, when they already have liver cancer. And so what is the process to being listed for a transplant? You talked about the MELD score, which is an algorithm of based on lab work of people's disease severity, that there are ways that we can, and as a policy perspective, we can and have been adjusting that over the years. A shout out to my kidney colleagues for getting EGFR deracialized. Yes. So what is the road to transplant look like if somebody needs that?
So typically we get our referrals for transplants from local providers. Our main referrals do come from local gastroenterologists or, maybe other hepatologists that are not at a transplant center. So we would get that referral. We would see the patient. One of our doctors or transplant hepatologists would see the patients. And then the evaluation pretty much starts from there if they're determined to be a candidate. And most patients that are referred are more than candidates. Sometimes, much later than they should have been. So we start the evaluation just in keeping in terms with HCC month. Patients that have hepatocellular carcinoma are placed on an expedited transplant path. So we try to get their evaluation done very quickly so that we can have them listed and they can have a good chance of accruing what we call the HCC exception points. So they would meet our multidisciplinary team. We try to, again, crack it down to the lowest time possible. It can be a challenge sometimes because people do have lives, and they are doing other things. A lot of these patients are still working. So we work with the patients very closely. We have our schedulers that call them and schedule these appointments. And then we present them at our multidisciplinary selection committee. I think it's probably pretty similar everywhere, where we are the advocates for the patients and we present their cases. And the majority of the time, they're accepted for active listing. And once they're listed, it's kind of like I throw a party in my heart because that's getting the access. We do have patients that have indications for transplant and they may be ambivalent. And my conversation with them is always, you want to have a shot at this. You want to have the access. Let's get you on the list and we can work towards that. But if you're not on the list, you don't have access. Another part to your question, Donna, is that I always worry about the patients that don't make it, that are dying in the community without ever having access. And those patients are missing from our data, right? So I believe that especially in minority communities where, liver cancer is so prevalent and so aggressive, our mortality rates are higher, even though overall they've improved. There are still patients that are undiagnosed, that are out in the field. And you'll often hear from patients, oh, my aunt died from liver cancer without treatment, or my uncle died from liver cancer without treatment. But you always rejoice over the ones that you could help, but you mourn for the ones that you could not have helped. So I think our focus needs to be, I think we all mentioned more community outreach in getting them into the door. It'll take grassroots work, maybe just patrolling the neighborhoods, doing mass mobile fiber scans on patients to pick up hepatic fibrosis and really create that pathway to access. So once they get in the door, we take good care of them. I make multiple phone calls. Get your A and B vaccines, this is the recommendation, we do the whole blurb from the AASLD. Once they get in the door, I think, for the most part, they're connected, but it's the ones that are not getting into the door that we have to really strategize to get them in the door.
Absolutely. Two things. This series, so that we can elevate the issues and start to put solutions out there, is really the first effort of GLI's Center for Liver Health Equity that'll be formally announced on October 17th in Washington, D.C. At the luncheon, where I know I'll see you as a past award recipient. And our community clinical trial ambassadors is the second output of that center. Really something that you inspired and helped us to really put some structure around about the skills that people would need to be able to be useful in their communities, to be able to listen and assess needs, to build relationships, both with community members and institutions and churches and groups, but also understand the researcher side. So have relationships within their institutions, and with physicians and the researchers, and understand how to navigate. Even the other day I offered to give someone a tour of the hospital so that it would be less, scary to them when they went for their treatment. And so somebody who can do that, really hands-on, demystifying and explaining for the things that sometimes the doctors and even the nurses don't really have time, or patients sort of hold up those questions and, don't want to ask, don't want to. And so to have someone who, particularly if they've had liver disease and have sort of successfully made it to the other side, to be able to spend that time with people and to be that bridge. So I'm really excited about GLI working throughout all the geographies where we have Liver Action Network members, which include New York, to be able to be a much more service-oriented presence in their communities. I really do believe that that's how we will connect all of this innovation and activity that is fantastic that we're seeing, but make sure that there's meaningful access to it. So, one of the things that we have talked about, Dr. Jones, is the need for both physician training and patient training, if you will. We've also talked about gastroenterology and hepatology reaching out to primary care. And so what can hepatology do to better engage their primary care and cardiology and endocrinology colleagues to understand that these patients with liver disease are their patients too?
Thank you. Yeah, I think part of it is making it easier and really trying to understand what our primary care and endocrinology and cardiology colleagues are sort of dealing with on a regular basis.
Mhm.
So I think when you become specialized, and really everyone is a specialist, even people
Mhm.
that are in primary care, that is their
Mhm.
specialty.
Right.
They sometimes actually don't remember what other people are doing on a day-to-day basis and sort of what their path is and what their work is like. And so I think making sure that we engage with our colleagues, and Rotonya mentioned earlier us being in silos, but I think that happens within specialties as well.
Sure.
Making sure that we take the opportunity to have multidisciplinary conferences, to communicate about patients that have been referred and the patients that we would like to see sooner, I think is a real key. I think anything you're trying to do, if you can make it easier for the person who's sending that patient to you, you're going to be more successful. So if you understand what's standing in the way of them sending someone to you, you're better able to develop a pathway. Perhaps they need a telephone number. I think a lot of our centers have tried things like that. Just a simple inbox, an email, if you have a patient, a phone number, something that makes it easier for them to send the person to get the help that they need. Because I think that's not their area of expertise. Just like I wouldn't be able to manage somebody with, cardiac disease, nor should I be expected to. So just really extending that invitation to engage with each other and being as helpful as possible when someone is sending someone to us. I think one of the things that has sort of set us back is that sometimes when someone has fatty liver, it's actually often dismissed, right? Sometimes that person doesn't get to the specialist because, a lot of the patients that I see have cirrhosis and their liver enzymes haven't been normal for quite some time. And their platelets are low as well. And it was sort of like, well, yeah, of course you have fatty liver. And it just the seriousness of it. So I think making sure that everyone understands that, yes, like Dr. Antwi said, there are a number of patients that are not going to develop the liver cancer from the fatty liver, but we don't want to miss the ones that will. So making it easier for them to understand, when there's a patient that has fatty liver, which are the risk factors for progression and which of those patients need to be seen, and then making it easier with innovative techniques like bringing care to the community, telemedicine. I'm hopeful that telemedicine will help to offset some of these trends because so many are not in big cities like we are, right? And so getting the care to people as easily as we can.
One of the policies for telemedicine, which seem to have impacted, depending on generations and communities, is reimbursing for phone visits as well as video, telehealth visits. Are there other policies, and anyone, Dr. Jones, you can start, but are there other
I can
policies?
mention, one of the things that I think, COVID taught us a lot of amazing things about how to deliver care. We've learned right now, I'm at work and everybody's expected to work. Why? Because we can work remotely, even in a hurricane, right? So COVID has taught us a lot about that. But one of the things that I think we have to focus on is advocacy and legislation. So one of the things that in the beginning of the pandemic that I was really hopeful for is that our licenses, which are restricted by state, didn't necessarily apply. And so we were able to see people if they were located in different states because people went to different states because for whatever reason they had to, family members ill. But that actually exception is going to expire. And now we're no longer able to see people. And if even I have a patient who lives in Florida, but they're visiting Texas, I cannot see that patient. And so thinking about ways that we can advocate to change the legislature and to make telemedicine services available to everyone, regardless of where they live. And then, of course, reimbursing for the time that's spent, because whether I see you on video or it's just telephone, we're investing a lot of time in understanding your care and explaining the treatment plan to you. And it really is not reimbursed. And so there's a disincentive for people to do it because, you know, unfortunately, we do have to think about that aspect of care and making sure that our staff is able to be, you know, paid appropriately, et cetera. So we do have to think about reimbursement for that simple reason. So us working with government representatives to understand how important this is to actually, you know, achieving health equity, I think is key. I think these are tools that we have. We just have to use them.
I could not agree more. The state licensure waivers are an important thing. We can't go backwards. That's the message that, you know, GLI and our policy team have been making to CMS and Congress, that, you know, we've learned so many things and put so many things in place that expanded the reach of healthcare to people. Why would we go backwards? And you listed one of the biggest barriers. And so we've worked with the government affairs offices of all of the different digestive medical societies on just that issue. And so it's important. I, you know, live in an urban district, and so I could go 4 miles to sit on the other side of the state line, to be in the same state with the endocrinologist that I just started to develop a relationship with, but other people can't. And to destroy the linkages to care that were developed during the pandemic, you know, just really seems foolish. And so that is definitely one of the larger issues, along with, you know, step therapy and prior authorization and other things that get in the way of the care that doctors are trying to provide their patients, and advanced you know, nursing practitioners as well are trying to desperately to provide their patients, and we can't have the barriers to that.
Just like to add that telemedicine really has been a boon for us, and expanding access, and especially for those patients who we're expecting to come in every 6 months to have lab work, to have ultrasounds checked. You know, they can have those tests done, and then we can, especially if they're okay and there's nothing, and we're going to say, look, you know, no evidence of cancer. Your hepatitis B is not progressing, and a lot of our patients are patients who are self-employed. They're taxi cab drivers. They really cannot afford to take a whole block of time off. And quite frankly, we're a city hospital. You're committing a morning to sitting in our waiting room, and it's a big deal. So this has really made a difference. It's also made a difference with our mid-level providers. We have PAs, not NPs, but they are people with telephone numbers. The hospital will give them a telephone, and the patient can actually call them and speak to a person. And that really makes a difference for improving access and improving patient trust in the system.
It absolutely does. And I want to continue with you, Dr. Culpepper-Morgan, because you mentioned navigators, and having navigators have been so instrumental in so many other disease states. But my, you know, our sort of landscape in GI and different cancer centers are not that there are not a lot of particularly GI cancer nurse navigators and navigators for patients with liver issues. Can you tell us more about the navigation that you have at your institution?
So we have two types of navigators. One really more administrative to get you where you need to go if you don't know where that is. I need to have a COVID test. I need to have blood work done. Where am I going? 4th floor in this building, 3rd floor in the other building. So we have people that do those calls, and then we have our PAs serving the other navigator function, which is more clinical. I was told to take this medicine. I'm feeling funny. I don't know what's going on. And to talk to about whether do you need to come back and see us? You need to just, can I just call in a script for you? It helps to have somebody that actually is a provider,
Right.
As opposed to somebody that is a trained navigator, because they're two different ways that they can take. We use the other type, for instance, going over maybe prep for colonoscopy and things like that. But to actually make some clinical decisions, it's just been very helpful to have mid-level. I'm very much a proponent of using PAs and NPs in practice, make all the difference, and can develop really wonderful relationships with the patients when the physicians are really just coming in and sometimes being too quick. But in order to navigate, you do have to have some training, and there is some time investment in that, depending on what aspect of your practice you want to deal with. We, for example, I think that practices that deal with more PBC, PSC, and things like that. We don't deal with that. So our that's not part of our training, but we do a lot of viral hepatic disease, and so our PAs are fairly expert in that. So I think that when practices are looking to take on mid-levels, they have to think about the training and what types of patients they're dealing with, and how they want to support them.
I think that's absolutely accurate. I would make a really great administrative navigator. I am excellent in colonoscopy prep and where things are in the hospital. But the rest, I would believe I'm not quite qualified, so I would excuse myself from that role. Does everybody have those at their institution? Raise your hands if you want those at your institution.
I want it.
Okay.
Can we talk about funding? The funding of those sorts of positions. Because I think that there's two issues. I think is that sometimes when you want to implement something, you have to show that it's beneficial. You have to study it, right? Even though it's logical. Like, how could more help be bad? But you have to show that it works, either research or from a cost effectiveness standpoint. And I think that is a challenge for a lot of institutions in implementing this sort of navigation that people need. And I feel like medicine's moved in the opposite direction of having you reach a human. It's like, use the portal, send an email. Like that's right. What we want you to do. We don't want you to talk because we don't have anybody to answer the phone. And that's a big problem, I think, in a lot of communities, is that you need to talk to someone, and that relationship that you form with a navigator, I think, is invaluable. So I'm working on a project to improve navigation in our highest risk patients with liver cancer, because they are falling through the cracks. Right. Sometimes people don't understand like how important it is that you go to that transplant visit, how important it is, and what we can do to help you. Right? We can help you with disability applications. We can help you with home health. We can help you with a lot of things if we know what needs you have. But really, there's not in standard practice where I am, we have to work really hard. I have to navigate a lot. And so having a navigator that could do a lot of those things and build a relationship, I think would go a long way towards establishing the trust. For even for this clinical research that we've talked about, but really feeling like somebody at that institution cares about you. I think let's hope we get there.
I think we can. And I think that that's also a point for advocacy. GLI is known for our clinical advocacy as much as for our political advocacy for just this reason. And the incentives in GI and hepatology, I think are sometimes misunderstood or represented to the boards of directors. I know at my hospital, or the larger hospital system, GI cancers are actually the number one, by volume, and yet we don't have GI cancer navigators. And so until there was a board member from who cared about GI. That question wasn't asked, and so that data wasn't presented. And so I think that part of our advocacy is lifting up GI and hepatology to their own institutions. So, you know, your requests for these services for your patients, for our patients, are greeted more favorably. Dr. Carr, how could these navigation services, one, be helpful at your institution, but two, how can we build these into the clinical guidances and workflow and other recommendations that I know we're working on with the different medical societies and issues? I think this needs to be part of what it means to deliver good care.
Yeah, no, thanks for that question. Very, very important. I am happy to say that we do benefit from some navigation in our division at some sites in certain disease areas, and we don't have to reinvent these wheels. We have really great guidance from those who work in colorectal cancer disparities that navigation works, and for over a decade have been used to navigators in that setting. At our VA hospital in Seattle, where I am, we have a really wonderful model for our patients with liver disease, having navigation there. And I would say on the transplant side, we have really incredible navigation. For the pre-transplant individuals, there is a large gap. And I think that is a real opportunity. And perhaps some of that is our societies can help resolve by putting more of an emphasis on pre-transplant care and early disease and prevention of advanced disease. And these are great ways to do that. And making sure that everyone has all of the information they need, even without needing the intense resources of a transplant team. I think most likely, as Patricia said, going to be cost effective. I don't know that we need a study, and in fact, I'll say it. I don't think we need a study to demonstrate that. So I think we create hurdles for ourselves in academia. We can't move until we have plenty of evidence in so many fields, including in our own, that we can just move forward with this. And so the question is there a will to do it? What will we have to give up to get this right? Because there is going to be a cost, and how are we going to design systems to really make this a priority?
I suggested to someone the other day that they give up their snack budget because I knew what that line item was. I was like, we could do a whole lot of stuff with just your snack budget if you like. But I was only half teasing. They have great snacks. But there are decisions that are being made in hospitals and health systems about where the resources go. And oftentimes it is not to care coordination. And so, but as we shift towards value-based healthcare, keeping people well, helping ensure that they have optimal outcomes from the care that they receive, not being readmitted to the hospital, being admitted to the home, but with support services so that they can actually thrive at home, are all increasingly aligning with the interests of the health system. And so I think that as we paint that picture of the incentives that align what's good for the health system with what's good for people, we can continue to advocate and push for these types of services.
I think unfortunately, what we had to do is our second. We were able to get our second mid-level based on colon cancer and colon cancer screening, because colonoscopies make money. And then because that's not the only thing that we do. And of course, it would be boring for the mid-levels to just do one thing. So we expanded, and now that's, job satisfaction for our PA as well as serving our patients. So I think a lot of times when you write these business plans, sometimes the business plan going along the hepatology route won't necessarily sell. And so I'm recommending for division chiefs, think outside the box. If you're going to get more support for a person, for a body, and a salary line, going down the colonoscopy route, do that, and then once the person gets there, then you can do some redesign. But oftentimes these are the things that you have to do to get the resources that you need in order to serve the community that we have.
Yeah, that's why I'm so excited that so many of you are chiefs of gastroenterology and hepatology. So I think that is really wise counsel. Dr. Golden, do you want to talk about how some of the methods that you use to get the funding and support for your program, so we can all learn from that?
So we basically went on a public announcement campaign. Again, like I think everyone mentioned, working in academia, everybody wants to see the data that's been there, that keeps coming, but you have to show the data because you're in academia. So we did a number of speaking engagements with other liver organizations, as well as within our department, in addition to reaching out to local agencies. So if somebody wanted to talk about it and looked like they had funding, we spoke to them. We also partnered with our Health Justice Center at New York Presbyterian Hospital, and they were of a huge support in terms of funding to getting things done. But I just want to say that a lot of bringing awareness is also bringing awareness to providers that are not like us. There's still a number of people that don't believe that there's provider bias or that there's any kind of bias. And we're all human and we have them. We just need to make sure that we keep them in check and that we acknowledge them. And I think that's the first step when you encounter patient relationships of any color. I think collaborating like we're doing now is very important, and being available to put the work in. It's not easy. Most of the things that we've done have been after hours into the morning hours, but that's what it takes. So collaboration definitely, and just keep speaking out publicly about the disparities, because people want to help, but if we don't ask for the help, we won't get it. So
I don't think anybody has ever said that Black doctors and nurses don't work hard enough. That will never be my message. So I'm so grateful for all the extra things that you do to go above and beyond to ensure that we receive the care that we deserve. Dr. Antwi, I want to bring this around to, as we're struggling even in the corridors of power in the United States to bring care to patients, how can we make sure that we are scaling everything we do so that it also works in Africa?
Yes. So in Africa, unfortunately, there's not enough funding for very thorough research. So you need to seek funding from the U.S. National Cancer Institute or other NIH agency for such work. We do apply for funding through some donor agencies as well. But most of the work that we are trying to do currently is actually by comparing Africans, native Africans, to African Americans. We have common ancestry. Do we have any risk factors that are common within those two groups? We already know that for African Americans, the primary risk factor for chronic liver disease is hepatitis C. For Africans, it's hepatitis B. The second most common one for both Africans and African Americans is alcohol abuse. Fortunately for us, we can eliminate these conditions completely. We can reduce our alcohol intake significantly to reduce our risk of getting cirrhosis and subsequently liver cancer. We can also eliminate hepatitis B with vaccinations. If we have a lot of people being vaccinated against hepatitis B, we significantly reduce the incidence rate. We can also treat hepatitis B very effectively with some of the new treatments that are on the market. Hepatitis C can also be treated very, very effectively with new direct-acting antiviral medications, which has a success rate of about 99% for some patient population. You can completely eradicate the virus from the body and subsequently reduce their risk of getting chronic liver disease and progressing to liver cancer. So we know what we can do in terms of the viral infection and the alcohol abuse. Funding that is needed, in my perspective, from my point of view, is that we need funding for genomic work. We don't know a lot about the genetics and genomics of liver disease in Africans and African Americans. Fortunately for us, we just received some funding from the NIH to sequence African patients. So we have a small number of African patients from Ghana and Nigeria, and we are going to do a whole exome sequencing to be able to see, we'll find some variants that are associated with higher risk for liver cancer. That is just the beginning. We are going to leverage that for much larger study, expand it to other African countries. And then we're also collaborating with some sites within the US, mainly in the southern part, southern states in the United States and Mississippi, in Alabama, and other areas, trying to accrue sufficient numbers of African Americans so we can do these native Africans versus African American comparisons to see if there are some common or different variants that predispose to higher risk. So we need a lot of funding. To answer your question, we do get some funding from the NIH, but usually we are doing something for the people in Africa, but we also have to do something for our African Americans here and African migrants here. The best study that can be done is to combine both in one group, where you can look at them together and look at them separately to be able to decipher some of the factors, the genetic factors that predispose to risk. Thank you.
Thank you. Dr. Carr, I saw you come on, and then I have a question as well, but Dr. Carr.
Oh, yeah, I just, first, I think that's incredible. I can't wait to see that resource be further developed. And one of the things I worked with a collaborative team at Penn before I moved on a Nash or a NAFLD GWAS study. And we saw that most of the studies, had been not very diverse. So we were able to leverage the VA's Million Veteran Program data set and combine that with a biobank at Penn, and then also compare it to a European data set. And, remarkably, we found over 70 new SNPs. Now, had we not done that, we would still be left with the same, 10 genes of interest, right? So I just wanted to say that's a really incredible endeavor. And please, just let all of us know how we can support you.
Excellent. I wanted to, give a shout out to, Dr. Charles Rotimi at NIH, and a fantastic young woman who was so involved in the development of the COVID-19 vaccine from the NIH side, who's now at Harvard. She's a total rock star. And just, I want to, in some ways, it's such a celebration. I feel we should have, certainly all of you here, but letting people know about all of the fantastic physicians and researchers of African descent who are working on these issues and are working behind the scenes. If nothing else gives you confidence about this research enterprise and about this care enterprise moving forward, and removes some reluctance to participate in it, it should be, shining a spotlight on all of you and all of them who are working on these issues for patients. So I just wanted to say that. So the question I had was about there were a lot of dollars in HIV, and as many of us have mentioned, a lot of the risk factors for liver cancer are also infectious diseases. They're viral diseases. And can funders for TB, malaria, HIV be doing a better job of incorporating viral hepatitis and other liver health issues in their funding mechanisms and structures? Dr. Antwi?
Oh, yes, absolutely. I totally agree with you. But I think we need to shout, we need to make noise about it. The pancreatic cancer team of their PanCan group network, and they are always making noise about the need for funding for pancreatic cancer. And we've seen that survival rates for pancreatic cancer has actually improved because of the efforts. We need to do the same kind of advocacy for liver cancer. It's severely underfunded, in my opinion. And I think we need to get to the funders. We need to get the attention to how severe this condition is. In most ways, liver cancer is similar to pancreatic cancer. It's actually very, very deadly. Only about 20% of the people survive within 5 years. In other words, 80% die within 5 years of diagnosis. Pretty severe. And most of the risk factors, as most of the clinicians have mentioned already, can be prevented. We can prevent them from progressing to cirrhosis and to liver cancer. We need a lot of funding to help with the risk prevention work and also treatment of people with hepatitis, et cetera, et cetera. So we need to get the funders on board, and we need to have a more stronger advocacy for liver cancer, both internationally and then nationally here in the US.
Absolutely. It's one of the reasons why I'm so excited that Dr. Francis Collins has taken on elimination of hepatitis C in the United States as his challenge. I could not hope for a better champion. Certainly, one of the world's best known geneticists and leaders in healthcare to rally our administration in our country around this issue. But I think even more can be done. I know he's just getting started. But as you pointed out, liver cancer is one of the deadliest cancers. So we cannot meet the president's goals in the cancer moonshot to reduce cancers by 50% without reducing liver cancer. And that's just a fact. And so the National Cancer Institute and NIH, but also CDC and HRSA and FDA and the VA and the Bureau of Prisons, and everyone needs to rally around this issue of reducing liver cancer if we are to make a mark and be a model for the world and be able to continue to give innovations such as liquid biopsies and more mobile imaging to make sure that we can reach everybody everywhere they are. And so I'll get off of my soapbox and invite you onto your own. And so maybe we'll just go around with a last word to close out this roundtable on the one message that you'd like to leave for any of our audiences, whether it's physician, patients, or policymakers that make the most difference in liver cancer. And I'll start with you, Dr. Carr.
Great. So many things that I could wrap up with. I guess I would just say that the liver community globally, really, we need to move more toward the preventive side of hepatology. There's so much opportunity there, so many things that we can do before patients succumb to the really dire consequences of advanced liver disease and the complications. And for the patients who are watching, or people who may not be patients but are in the community and have loved ones who may be at risk, really know about some of the key liver disease risk factors and ask to get checked. So obesity, diabetes, prediabetes, these are risk factors, by the way, not only for fatty liver disease, but for other liver diseases as well. Ask your doctor or other provider to get your liver tests checked, get a hepatitis C check find out your vaccination or immune status to hepatitis A and B. These are things that everyone can do to, play a part in their own risk reduction. And finally, I just wanted to put a plug in for living donation. That's not something that came up today, and I think probably a lot of people watching have never heard of this. But if you find yourself in the position, or your loved one who needs a liver and in need of a liver transplant, and you get access to that list, remember, you don't have to wait for someone to die to get your transplant. You can actually get a part of a liver from a living person, and that's called living donation. And we really need to get this word out to our communities, because this is an area where we definitely are not getting to people of communities of color. My university is number 3 in the nation in living donation, and Dr. Bamba always says, living donation is the first best option. And so those 3 things I would like to leave your viewers with, and I hope that we have an opportunity to talk more about that in another forum.
We will. Dr. Jones?
Thank you. Dr. Carr gave so many good tips and a lot that I was thinking of. So as she was speaking, I was thinking I had to pivot, obviously. But one of the things that I think my message would actually be for our institutions. I think we can do a lot more than we're currently doing. Some of us work in various settings, the VA, safety net settings, private hospitals. And I think that there's a lot that we can do in terms of getting to know our community organizations and how we can best partner with them to reach patients. That includes like federally qualified health centers, but also nonprofits that are working to help with needs that have been identified in the community. I think that's our best chance of understanding what the needs of our community are, so that we can target our message and our approach appropriately. So I would say I charge all of our institutions, all of us working at our institutions, to do a better job and to actually start to become a neighbor to our community and to help them address the needs that are most important to them.
Excellent. Dr. Golden.
I just want to funnel off of Dr. Jones. I think my message would be for providers, right? So I'll first start with me. I think that healthcare is community, and we have to do a better job at reaching patients where they are, or I won't even say patients, people, humans, and really connecting and building strong relationships. And healthcare has always been a you come to me situation, where we expect people to drop their lives and make this appointment and those things, because it makes it easier for us. But I think we have to shift our focus. I think we have been, and we have to continue to do that more intentionally, to really advocating for the people that are out there that can't do it the way we want it, or the way that's easy for us. And we have to meet them where they are, because that's what we do. So so that's all I have to say. Thank you, everyone, for all your comments as well. Thank you.
Dr. Antwi.
Yes, I would like to re-echo the suggestion by Dr. Carr. We all need to get tested. If you think that you've been exposed to someone who has hepatitis C or B, please get tested. It's important to get tested because it can be treated. We can eradicate the virus from your system completely, and you can go on to live a very healthy, normal life. So get tested. Get tested. For my friends in Africa, I tell you that you also should get tested for viral hepatitis B. And even if the viral load is low, get it treated and vaccinated as well. Because we are seeing a lot of young Africans coming up who were told initially that their viral load is low, they don't have to do anything about it, and later on they develop cancer and die very young. The average age of liver cancer diagnosis in Africa is around 42, 43 years old. That is pretty bad. Most of it is caused by hepatitis B. So please get tested, get treated, vaccinate yourself and your children as well, so that you can reduce your risk of getting this disease. And when the opportunity presents itself, make sure you get involved in research. That is how we understand the disease process, so we can develop strategies for prevention and for treatment. It doesn't take much to contribute to research in terms of blood donation. When you go to your doctor for regular wellness check, your annual exam, and they are going to have a blood test done, most research studies require is a tube of blood. We just add an additional tube. You get just one needle stick for your regular clinical purpose, and then we add an extra tube for research. And that is what we use to study the genetic and the molecular factors that contribute to liver cancer development. So please get tested, get involved in research, and thank you all for listening. Thank you to my colleagues as well.
Thank you. Dr. Culpepper-Morgan, I'll give you the last word before my own.
Wow, what a responsibility. I have two things to say, because like everyone else, I've had to curate my remarks because so many great suggestions have been given already. But I would say for institutions, please support mental health. I do believe that many of the patients that I have seen who actually have advanced liver cancer have mental health challenges, and that have made them reluctant to go to the doctor, reluctant to follow up, or unable to follow up. We have a lot of homeless. So that support of mental health infrastructure will help many diseases, not just liver disease, but certainly I think it would help our patients to be able to comply and to participate meaningfully in their own care. And then lastly, I would encourage all gastroenterologists and hepatologists to provide educational sessions to your PCP colleagues regarding simple things that they can do regarding screening for liver diseases, the viral hepatitis, when to refer. These educational sessions, I think, are invaluable, and many times our colleagues don't know just how important or just how treatable some of these liver diseases are, and they're pleasantly surprised. So I would encourage education of our colleagues. And I would like to thank you, Dr. Carr, for putting this together, and all my colleagues for everything that I've learned today. I think it's been a great session.
Thank you so much. Thank you, all of you. And thank you for those of you who are listening and watching. We certainly have our marching orders. Liver cancer is one of the deadliest cancers, but it, in many cases, is preventable. So it is a message of hope, but it is a message of action. We've heard today that there's not only extensive set of issues, but an extensive set of solutions of things that we can do, whether we are advocacy organizations, patients, community members, policymakers, providers, or healthcare institutions. So I say we get on with the work of doing it. Please watch the rest of our series as we delve into the issues that are faced by our Latino, Hispanic colleagues, our Asian and Pacific Islander colleagues, and our LGBTQA+ communities with their own sets of challenges as we address liver cancer. You can find more information at globalliver.org and on all of our social media. Here's to living healthy, happy, whole lives. Thank you.